Good morning. I'm Ilene Ruhoy. I am a neurologist and I see a lot of EDS patients, and I was asked to present on the topic of pain and EDS. And I am very happy to be here, albeit virtually, but let's get right into it. Ehlers-Danlos syndrome, they are a heritable connective tissue disorder group. There are 13 clinical EDS subtypes that comprise defects in about 19 different genes. We've been able to identify these defects that contribute to almost all of the subtypes, of course, the most common being vascular, classic, and hypermobile. And these defects usually have something to do with the synthesis of the primary architecture of the collagen fibers, or their modifying enzymes, or different molecules of the extracellular matrix, which plays a very critical and important supportive role of the collagen fibers. Which include not only non-fibrillar collagen fibers, but also some proteins such as proteoglycans and glycosaminoglycans. Some of the defects have to do with transcription factors. We've even identified some components of the complement pathway. But the hypermobility type has been elusive. We have not yet been able to identify the genetic underpinning of the hypermobility type of EDS. And so there, sometimes people will call it joint hypermobility syndrome or hypermobility spectrum disorder. But regardless, these connective tissue disorders all have a component of connective tissue failure. And there's poor wound healing often, elasticity of the skin, vessel fragility, easy bruisability. And in fact, there could be a tendency to bleed in some. And then, of course, joint hypermobility. Chronic diffuse pain is very common. Patients complain about it at least at some point in their lives, usually early on, and it usually evolves to increase in severity and frequency. It usually evolves to include more parts of the body. In fact, chronic pain is considered a comorbidity. Arthralgia and myalgias are the most common concern, but we see quite a few of central pain syndromes, such as CRPS and central pain syndrome, central sensitization. And that comes from just years of chronic pain that over time, it seems to be disproportionate to either the initial injury that could have started it or the inciting event. But very often you don't identify an inciting event or where it started or even how it started, especially if someone's been in pain for so long, because you often get a story of very early on in life that it started with either dislocations, sprains, they call it growing pains, that could then evolve into just having some muscle cramps or periarticular inflammation, sometimes like a tendinitis or a fasciitis. But usually the history also includes, even as a young person, they'll have what was called at the time functional abdominal pain or pelvic pain or different types of headaches. Oftentimes there's a level of fatigue and dysautonomia, which can contribute to the poor tolerance of the pain. So there's lots of things that go into the concern of pain for EDS patients. So what is pain? The International Association of the Study of Pain define it as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And it's obviously acute and chronic pain. We all know what acute pain is. It's sudden onset. It's self-limiting often. Sometimes it needs some intervention. But it's 6 weeks if the pain that was labeled as an acute pain did not heal, then it becomes chronic pain. And this is very often the case with EDS patients because they might hurt a joint. They might sprain a joint. They might bruise a muscle. They might sublux, for example. And then you would think that pain would easily resolve, but it very often doesn't. And so that chronic pain becomes disproportionate, as I had said, to the initial injury or the inciting event. And then there's this level of central sensitization, which is thought to be due to increase in the excitability of the spinal cord neurons. So the International Association of the Study of Pain sort of has this very large classification and sort of breaks down pain into different categories. One respect based on region of the body. And I adopted it and edited it just for sake of brevity. But it's interesting to me that many of their categories really do apply to EDS patients because we hear of concerns of pain from various different anatomical concerns. So neuralgias of the head and the face, we have a lot of occipital neuralgias, trigeminal neuralgias, glossopharyngeal neuralgias. musculoskeletal origin of the craniofacial structures, of the suboccipital and cervical structures. There's lesions of the ear, the nose, and the oral cavity. There's a lot of headache syndromes basically due to either different intracranial pressure aberrations or CSF leaks or cerebral blood flow problems. Or just because of the neuralgias or because of cranial cervical instability. So there's a lot of different reasons for certain kinds of headache syndromes. There does seem to be a high incidence of not only headaches, but migrainous type headaches as well. Obviously, spinal and radicular pain syndromes in all regions of the spine, and as well as local syndromes of the upper limbs and generalized syndromes of the upper and lower limbs. So pain in the shoulder, arm, and hand are very often problematic, often the shoulder. In fact, many patients have to ultimately go for reconstruction of their shoulder. And sometimes the small joints of the hand are involved, and vascular disease of the limbs, collagen disease of the limbs. So all this very much applies to our patients. So also visceral and other syndromes of the trunk apart from spinal and radicular pain. So visceral and other chest pain. I had a patient a couple of weeks ago whose heart was now on the other side of her chest, and she had lots of pain because everything was just turned around from lack of being held appropriately by her connective tissue. Chest pain referred from the abdomen or GI tract. Abdominal pain of neurologic origin, abdominal pain of visceral origin, abdominal pain syndromes of generalized diseases. We see a lot of, things like celiac artery compression, and a lot of dysmotility causes sometimes just frank gastroparesis, which can be very painful. Diseases of the bladder, uterus, ovaries, and adnexa. There's a high incidence of endometriosis and interstitial cystitis in these patients. And then, of course, pain in the rectum and perineum and external genitalia. And then, of course, local syndromes of the lower limbs of either neurologic or musculoskeletal origin. Very often the knees, the hips, and the ankles are involved. So why pain? Well, connective tissue is everywhere. It's in our joints, obviously. It lines our vessel walls. It's part of our skin. The dura actually is known to contain mostly fibrous tissue. And as you know, the dura helps to protect the intracranial structures, and it's a very important anatomic spot for CSF turnover. The connective tissue holds our viscera in places where it should be. And even our peripheral nerves, the endoneurium contains fibrous sheaths that has not only collagen fibers, but blood vessels and fibroblasts. And while they're found on all peripheral nerves, they're much thicker. The sheath of the collagen is much thicker over myelinated nerves. And so this explains the heterogeneous nature of the phenotypical presentations that we see. It results in just many different manifestations. And that's what can be difficult for patients because connective tissue is so ubiquitous, there could be involvement almost anywhere. And so oftentimes the pain won't necessarily localize all that easily, which can be problematic when they're seeing neurologists. And oftentimes the pain can be hard to treat. So more of why pain. So there's compromise of the collagen biosynthesis, right? So when you have compromise of collagen biosynthesis, you have poor collagen. And the collagen is either fiber forming, which is sort of the main part of the collagen. And then it's stabilized by cross-linking, and it's supported by the fiber non-forming or non-fibrillar collagens, which helps to make, basement membranes and covers the peripheral nerves, as part of the endothelium. And it's important to recognize that so that there are 5 types of fibrillar collagens, 1, 2, 3, 5, and 11. Actually, while they are made at greater amounts than the non-fibrillar collagens, they are very much reliant upon the non-fibrillar collagens because it's those non-fibrillar collagens that really support them and make them stronger and keep them tight and anchor them to groups of surrounding tissue. And the non-fibrillar collagens are very rich in glycine and proline and hydroxyproline. And so they basically help to anchor and form a network of the collagen fibers. And so when there is just compromise of collagen in general synthesis, then you basically have weak collagen, and that can be problematic for our anatomy. It can be problematic for our physiology. So in addition to pain being a comorbidity, there's actually many other comorbidities of Ehlers-Danlos syndrome patients. And a lot of these are either pain syndromes of themselves or contribute further to pain syndromes. So mast cells, for example, are very well known to contribute to pain sensations. They are located in a perfect location because they are at that tissue environmental interface, and they are very close to nociceptive neurons. And so when they degranulate upon activation, they release certain mediators that then activate the nociceptors. And in turn, the nociceptors release mediators that then activate the mast cells. So it's this cyclical event of just releasing of mediators that can cause pain. And, the literature, there's just tons of it that associate mast cell activity with pain disorders. And I listed a few here, but migraine, interstitial cystitis, dermatitis, fibromyalgia, vulvodynia, CRPS, irritable bowel syndrome, neuropathy, and postoperative pain. Postoperative complications in EDS patients are very common. And one of the things that we've learned and are currently trying to study at Mount Sinai South NASA is if you really manage the mast cells both preoperatively and postoperatively, how well do they do in the post-op state? But going back to the mast cells, they release a lot of different mediators, the histamine, the tryptase, the serotonin, the bradykinin, and TNF, and some of the interleukins, as well as some of the other cytokines, really do contribute to chemical, infectious, or allergen-induced hyperalgesia. And so, the mast cells, substance P can actually provoke mast cells through a mediator, but then the mast cells also release substance P, and that's also a well-known pain mediator. And then sometimes some of these other cytokines in the histamine and the serotonin, for example, just help to produce sort of the final end product of leukotrienes and prostaglandins, which also contribute very much to pain. And then with, the mast cells are part of our innate immune system. And so with chronic innate immune activation, because the mast cells are in such high volume along those connective tissue interfaces, that eventually the mast cells are robustly recruited to then draw the adaptive immune system, basically. And so then the adaptive response then results in autoreactivity and sometimes just frank autoimmunity. And autoimmunity has been well associated with pain just from neuropathy that it can cause, of vasculitis that it can cause. And so when you have autoreactivity and potentially autoimmunity, you could have further breakdown of connective tissue, as well as antibody binding and deposition of immune complexes in tissue, which can then cause, of course, organ dysfunction, sometimes even molecularly channel dysfunction, leading to organ dysfunction, which can cause its own pain syndrome as well. Small fiber neuropathy is a very common feature of EDS. It affects the small, unmyelinated, and thinly myelinated sensory and autonomic nerve fibers, and this can be confirmed by a skin biopsy that shows a decrease of the intraepidermal nerve fiber density. The small fibers are generally pain fibers and autonomic fibers. And so very rarely does a patient report weakness, though when you ask these questions, they will describe a certain fatigability of their muscles because many patients have either post-exertional malaise or post-exertional fatigue, or sometimes even just cognitive malaise, cognitive use malaise and cognitive fatigue. So there's no true weakness on exam usually, unless of course there's a motor neuropathy, which is not nearly as common as small fiber neuropathy. And often it's a hyperesthesia or allodynia rather than a sensory loss. So you'll hear things like burning and stabbing and shooting as descriptors of the kind of pain that they're feeling. It could be length dependent. It could also be multifocal because the small fibers just sort of don't really follow any grid necessarily, which is why we take several biopsies when looking for small fiber neuropathy. We generally take 3. And because the small fibers also include autonomic nerve fibers, there's often vasomotor dysregulation, and that can change either the skin color or the temperature of distal limbs. And that can contribute to the neuropathic pain sensation. Raynaud's might be present as well. Patients can develop frank postural orthostatic tachycardia syndrome or orthostatic hypotension, or any other level of dysautonomia. There's often impaired sweating, which is interesting because there's an interesting pattern of excessive sweating of the head and the neck. In fact, I had a couple of patients who tell me that they have to put their head in the freezer in the morning in order to get to work because they're just sweating so much, but yet there's impaired sweating more distally. So I think that's a little interesting. And then there could be other autonomic symptoms like postprandial nausea or bloating, certainly slower motility of their GI tract. I mean, very commonly you hear about constipation. Occasionally there's some diarrhea, but sometimes just frank gastroparesis. There could be all kinds of different changes just from an autonomic perspective, like even urinary retention, and then different complications of just feeling lightheaded all the time. So what treatments can be done? Well, there's lots of manual therapies for EDS to help sort of reduce the pain and improve the mobility of the joints and of the body overall. Physical therapy, occupational therapy, and body work are definitely cornerstones of therapeutic modalities for EDS patients, especially those who are in pain. Very often it can be preventative to avoid pain. Then there are medications. There's a whole list of medications, and I obviously listed probably too many, but, all the neuropathic pain meds, some of the tricyclic antidepressants, mast cell stabilizers, antihistamines. It's important to recognize that the mast cells release almost 1,000 different mediators. So sometimes stabilizing the mast cells is a lot more effective than the antihistamines. Then there's lots of topical formulations that I've over time have used. Non-pharmaceutical can be, some of the electrical therapies that are out there, like the TENS. Certainly, there's a lot of natural pain remedies that can be done. Nutrition, I think nutrition is always important. I think a good nutritional plan can only help and not make things worse. And I always talk about how foods can be anti-inflammatory versus pro-inflammatory, and to always choose anti-inflammatory when you can. And then there are some peptides that are actually real important. GHK has a high affinity for copper, which is important because copper is very important for a lot of different body functions. And it's been used, for wound healing because it's so good at helping support the production of collagen while also helping support the removal of damaged tissue, and also impairs the formation of scar tissue, which can contribute to pain later on. It really does seem to help stabilize some of the collagen fibers for a lot of patients who have been in pain. It doesn't work quickly. Certainly, it comes as an injectable and as a cream. In fact, it comes as a cream formulated with BPC, which is the other one, which is also very anti-inflammatory and analgesic and supports wound healing and tissue healing. GHK also supports angiogenesis, so that also helps with regards to wound and tissue healing. So it's just been very helpful. And these are physiologic peptides. So GHK is found in our blood, in our urine, in our saliva. But as we age, certainly, or as we're chronically ill, we actually lose our reservoir of GHK. So it seems that supplementing with the injectable form of this particular peptide is very helpful. And then, of course, there's different surgeries, musculoskeletal surgeries, obviously fusions, tethered cord, to detether the tethered cord can help reduce different types of pain. Surgery is always an option. Again, these patients will often have a lot of post-op complications, so it's really important that everything that can be managed preoperatively be done, and then obviously post-operatively to sort of really keep on top of now likely flared pain, but also any other physiologic comorbidity that might have been flared due to the surgery itself, such as the mast cells and such as the small fiber neuropathy and even the level of dysautonomia that can be present. Sometimes when there's an inflammatory flare for any kind of reason, be it surgery or lots of patients have had histories of infections, for example, then once the connective tissue starts to break down from the inflammatory assault, you can have lots of other problems. Things like rectoceles and other like hollow organ ruptures, different cardiovascular complications, different pulmonary complications. So it's just important to sort of keep on top of anything that might flare an immune response. And so these are my references, and it was really great talking to you. I hope you enjoyed this talk, and please feel free to ask any questions. Thank you so much.
Ilene, that was very informative. We're going to ask you some questions if you don't mind. We're going to pass microphone to our audience here, and you can't see them, but if you can hear them well, just let me know.
Okay. I apologize for all the audio issues. I was trying to mute myself because I have a house full of a sick kid and sick husband and dogs, so I didn't want a lot of background noise, so I apologize.
Everything worked out well. You kept them very quiet. Very, very impressive. Go ahead.
Hi, thank you. So peptides as treatment, I have not heard of that. That sounds very intriguing. Are they all injectable? Do you have orals? What are the indications and how accessible are they?
So they are accessible. There's a couple of compounding pharmacies in the country that do make them. To be honest, there are many peptides. I really only use the ones that I mentioned, only because they do have a role in EDS patients and connective tissue disorder patients. And we get them from a compounding pharmacy. I have noticed recently that patients have told me they've found them online at these internet pharmacies, and I've always sort of explained that peptides have a half-life. They're physiologic, and so I worry about whether they're getting viable peptides. So there is that move now that people can buy them online, but I always recommend going with the compounding pharmacies that require a prescription from a physician. And those two that I mentioned are really the only ones that I use, and they've been very helpful for a lot of my patients.
That's great. Thank you.
You're welcome.
Any other questions for Dr. Ruhoy?
Ilene, that was wonderful. We have another talk coming up on Ehlers-Danlos, and I'm sure there'll be more questions after that.
Yeah, absolutely.
Do you think you can just stick around just a little bit longer, maybe for another half hour or so? And if we need your help, maybe we can ask you for it.
Yeah, for sure. Absolutely.
That's wonderful. Thank you very much for joining us today. It's remarkable you were able to pull this through. So thank you.
Thank you again for being patient.
You can see us, but there's a lot of happy, smiling faces in the audience, and people are very appreciative of what you did.
Well,
thank you.
I thank you all. Thank you.
Thank you.